Hello there, my highly valued and treasured viewers and listeners. Welcome back to part 21 of our Pharmacotherapy MCQ series. My name is Dr. Nath Arwa and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I kindly urge you to sit back and spare me part of your precious time as I impart crucial tips that will assist you in your line of duty. Welcome. In the first question, a 57-year-old African American patient presents to the cardiology clinic at your hospital for his routine clinical appointment. He has a past medical history significant for dyslipidemia and type 2 diabetes mellitus. Today's blood pressure stands at 137 systolic, 85 diastolic. He has a heart rate of 81, and while at home he read his BP and it averaged 135 systolic and 86 diastolic, and his heart rate was 82. He informs you he exercises 5 days a week and eats a healthy diet. He is currently taking 20 milligrams of Lisinopril once daily orally, together with 25 milligrams of Hydrochlorthiazide every morning after breakfast. His potassium levels today were 4.9 milliequivalents per liter, and he registered a creatinine clearance of 80 milliliters per minute. So my question to you is, which of the following would be the best therapeutic plan for him? Would it be no medication changes are necessary currently? Or would you add 25 milligrams of hydralazine taken every 8 hours orally to the current regimen? Or would you replace hydrochlorothiazide with a superior thiazide diuretic Chlorthalidone at a dose of 25 milligrams after breakfast? Or would you increase his Lisinopril dose to 40 milligrams once daily? I'll give you 10 seconds to choose the correct answer. So I would swap hydrochlorothiazide for a superior diuretic Chlorthalidone at a dose of 25 milligrams taken orally after breakfast. And the basis of that is the ACC/AHA hypertension guidelines recommend a goal of 130 systolic, 80 diastolic for the general population and for diabetic patients. For African Americans, thiazide diuretics are the recommended or preferred initial treatment. That shows you why I opted for Chlorthalidone, which is a preferred thiazide type diuretic due to its long half-life and proven reduction in cardiovascular risk. Chlorthalidone is more potent than our previous choice, hydrochlorothiazide, and would provide additional blood pressure lowering for this particular patient. Now, this patient, in my opinion, is not yet at goal, so a change in regimen is warranted, and that makes answer A wrong. Answer B is wrong as well, so is answer D. Hydralazine isn't one of the first line agents due to lacking supporting evidence. And then increasing Lisinopril dose may prove dangerous. It may be a double-edged sword. ARBs like Lisinopril can cause hyperkalemia, and that would make his potassium levels worse. Remember, he's already high at 4.9, so we don't want it to go into the hyperkalemia range. That justifies why I would settle for Chlorthalidone, at a dose of 25 milligrams after breakfast. Let's move to the next question, which reads, which phase of the action potential of nodal cells is affected by class 4 antiarrhythmic drugs in the heart to slow the pulse or the heart rate? Is it phase 0, phase 1, 2, 3, or 4? I'll give you 10 seconds to choose the correct answer. So phase 0 it is. Now class 4 agents such as diltiazem and verapamil are known to inhibit phase 0 of the nodal cell action potential, which is when calcium influx occurs. Calcium influx into cells occurs in phase 0. Now when this happens, this slows down the AV nodal conduction, reducing the pulse rate. These two drugs can potentially increase the heart rate or heart pulse in a patient with a rare disease, Wolff-Parkinson-White syndrome, but they can't do so in normal patients. And nodal cells do not have phases 1 and 2, so answers B and C are wrong. I would settle for answer A, phase 0. Let's move to the next slide. Which of the following cytochrome P450 enzymes is inhibited by amiodarone, which also significantly affects the metabolism of warfarin? Is it 2B6, 2C9, 2D6, or 2C19? I'll give you 10 seconds to choose the correct answer. So amiodarone strongly inhibits CYP2C9. Warfarin happens to appear in two enantiomers, a mixture of two enantiomers, the S and the R, and it's R that is responsible for majority of the clinical effects and the toxicity exhibited by warfarin. It is 5 times more potent than the R form. Now both of them are metabolized by the CYP450 enzymes. Now, amiodarone is a potent inhibitor of a number of CYP450 enzymes. For example, 2C9, 1A2, and 3A4, which are all largely responsible for the metabolism of warfarin. Inhibition of these enzymes by our antiarrhythmic amiodarone, which is very commonly co-prescribed with warfarin, cardiovascular disease patients, what results is an increase in plasma concentrations and a decrease in the clearance of both S and R warfarin, thereby increasing the patient's prothrombin time and INR. This places the patients at a significant risk for bleeding complications. Initiation of amiodarone in a patient who is already receiving stable doses of warfarin will potentiate the action of warfarin, resulting in an increased risk of bleeding, of hemorrhage complications. Now, the effect of this interaction are typically seen somewhere within the first 2 weeks of initiation, and usually within a few days in very rare cases. Now, in some patients, the manifestation of this effect may not be evident for several weeks. There are rare cases as well. And because of the severity and the consistency of this drug-drug interaction, it is recommended that the dose of Warfarin be reduced, and I underline the word reduced, by a third to a half when initiating Amiodarone therapy in a patient who was already on Warfarin. Given the long half-life of Amiodarone, several dosage adjustments may be required before the patient's new Warfarin dose is finally determined and the INR has completely stabilized. It will not happen in a flash. It will call for patience. So you need to advise your patients about it. And this would especially be true in patients whose Amiodarone dose has been changed as well. So the two will keep seesawing, and it calls for patience and partnership with your patient. Let's move to the next slide. So according to the ACC/ABC/APA/AGS/ABC/ASPC/AMA guidelines, which are almost at a consensus for the management of hypertension, what is considered normal or desired blood pressure for a healthy adult below age 60? Is it below 120 systolic, 80 diastolic? Or is it below 130 systolic, 80 diastolic? Or is it below 140 systolic, 90 diastolic? Or is it below 150, 90 diastolic? I'll give you 10 seconds to pick the correct answer. In my opinion, below 120 systolic, 80 diastolic is the correct answer. The current guidelines indicate that a normal BP is below 120/80, whereas a BP between 120 to 129 systolic and below 80 is considered to be elevated blood pressure. Now, a BP between 130 and 139 systolic and then 80 to 89 diastolic is considered stage 1 hypertension, just for your information. Let's move to the next slide. A 60-year-old Hispanic male presents to the clinic with a past medical history significant for coronary artery disease. He's had 2 MIs. He suffers from type 2 diabetes mellitus. He is hypertensive and he also has dyslipidemia. He reports that he generally feels great, but continues to report occasional angina episodes, which tend to occur only when he overworks himself, in his own words, such as walking quickly when he's running late for an appointment or when he's under a lot of stress to achieve. He notes that these angina episodes occur about 3 times a week. Now, based on this information, how would you classify his angina using the Canadian Cardiovascular Society classification system? Does he belong to class 1, 3, 4, or 2? I'll give you 10 seconds to choose the correct class for this gentleman. So he belongs to class 2. Remember, he experiences angina that doesn't limit his ordinary activity. It only occurs when he overworks himself, quote unquote, which places him in the CCS class 2. Now I'll just break down the classification. In class 1, we have those in which ordinary activity such as walking, climbing the stairs does not cause angina. Angina only occurs with strenuous or rapid or prolonged exertion at work or recreation. Class 2 encompasses those that have slight limitation, and their angina occurs when they are walking or climbing stairs rapidly, walking uphill, walking or stair climbing after meals, or when it's cold, or when it's windy, or when they are under emotional stress, or during a few hours after wakening. Now, walking more than 2 blocks on the level or climbing more than a flight of ordinary stairs at a normal pace and normal conditions can also trigger angina in such patients. Now, in class 3, there is marked limitation of ordinary physical activity, and they experience angina when walking 1 or 2 blocks on the level or climbing 1 flight of stairs in normal conditions and at a normal pace. And in stage 4, or class 4 rather, the patients here have inability to carry out any physical activity without discomfort, and angina symptoms may be present even when they are at rest, so they are grossly limited. Just for your information, I'll move to the next slide. AWO is a 45-year-old female patient with a history of SVT. She presents with the A&E with a chief complaint of that the SVT she regularly experiences is back with a bang. She is hemodynamically stable and in no distress by the time you see her. She has palpitations consistent with her previous episodes of SVT, and the same is confirmed using an ECG or an EKG. The clinical team is preparing to administer the drug of choice, adenosine, via injection, but our dear lady AWO declines because she has received adenosine several times in the past and she was not amused by the symptoms. She experienced severely uncomfortable adverse drug events. The team would like to attempt pharmacological intervention before electrical cardioversion. So my question to you as part of the team is, which of the following strategies would be the most appropriate recommendation at this time? Would you administer nicardipine 5 milligrams hourly via infusion? Or would you administer 0.125 milligrams of digoxin by infusion? Or would you administer 300 milligrams of amiodarone IV over 1 minute? Or would you administer 10 milligrams of verapamil over 2 minutes? I'll give you 10 seconds to choose the correct answer. So I would settle for D and administer 10 milligrams of verapamil IV over 2 minutes. Now, just for your information, adenosine administration is associated with adverse events that can be distressing to very many patients. Although it's considered first line, Non-dihydropyridine calcium channel blockers such as verapamil and diltiazem are considered second-line therapy. Now, beta blockers can be considered third-line pharmacologic treatment. So, if a patient can't handle adenosine, you may have the option of falling back to those two classes. Now, these therapies should only be used if the patient is hemodynamically stable, and I underline hemodynamically stable, and do not have heart failure. If they don't meet those two conditions, I would be reluctant to use either a calcium channel blocker or a beta blocker in such patients. Digoxin, which is alternative B, may be used for SVT. However, it requires 24 hours to complete the loading dose. So for our patient, it would not be our best bet. The dose of amiodarone would only be utilized for patients without a pulse and in VTAC or VFib. So I wouldn't settle for C either. Now, the common side effects of adenosine that scare off our patient include flushing, chest pressure, neck pain, and dyspnea. She doesn't want to go through any of those today. Now, verapamil is thought to cause more vasodilation than diltiazem. That's what makes me opt for D. Now, if hypotension is a concern before the administration of these calcium channel blockers, then you may be advised to consider administering IV calcium gluconate just for purposes of blunting the vasodilatory effect of the calcium channel blocker, so that they don't get grossly hypotensive even as you intervene. Let's move to the next question, which reads, PBJ is a 30-year-old African-American male patient who presents to the accident and emergency with what he calls a crushing chest pain. His past medical history is unremarkable, but his father died of a heart attack at a very tender age of 39 years. So there's a family history there. His social history involves drinking of alcohol, smoking of cigarettes, and he uses cocaine. And on his ECG, you notice a T-wave inversion. His cardiac biomarkers are negative, and he has a current blood pressure of 176 systolic, 102 diastolic. His pulse rate is 110, pretty high. He has a respiratory rate of 16 and a temperature of 36.8. He is grossly desaturating, 88% to be precise, on room air, and you make a wise decision to intubate him. Sorry, to fit a mask in position, and after initiating the oxygen, he is currently at 92% on 2 liters of oxygen. He currently takes aspirin, nitroglycerin, morphine sulfate, lorazepam. So, in your opinion, which of the treatment options listed below would be the most appropriate to achieve blood pressure control in our patient PBJ? You strongly feel 176 is too high for this 38-year-old man, and you'd like to bring it down. I'll give you. So, would you opt for metoprolol, succinate, furosemide, diltiazem, or eplerenone? I'll give you 10 seconds to choose from that list of 4. Personally, I would choose to administer diltiazem. The management of cocaine-associated chest pain and MI, as published in Circulation, recommend using calcium channel blockers for management of blood pressure, and they are quoted to be superior to the beta blockers. So diltiazem would be advantageous over metoprolol succinate. Now, the reason calcium channel blockers are preferred in cocaine-induced ischemia is because, or is due to, the avoidance of unopposed alpha adrenergic activity, which could lead to worsening of coronary vasoconstriction. Clinicians should use beta blockers with some degree of hesitation. Don't rush to metoprolol in this case. Now, there is an exception, which is labetalol, that is likely to be the safest and most effective among the beta blockers. If you are forced to opt for them, go for labetalol. Now, the AHA guidelines also recommend the early use of benzodiazepines, such as diazepam or lorazepam, in the management of such patients who have overdosed cocaine and are experiencing chest pain, and it gives them a class 1B recommendation. So I'll move to the next question, which reads, a 48-year-old Brazilian residing in the city of Nairobi was started on hydrochlorothiazide at a low dose of 12.5 milligrams taken orally after his breakfast. Now, 7 days ago, he was put on that drug in response to a clinic blood pressure of 149 systolic, 97 diastolic. Today, her blood pressure stands at 143, it has come down slightly, systolic, and 93 diastolic. And her overall blood pressure goal is less than 140 systolic, 90 diastolic. Now, 1 week ago, his sodium was at 140, today it's 138. His potassium was 4.3, today it's 3.9. His chloride was 99, it has come down slightly by 1. His BUN was 13, it is 16 today. His serum creatinine has changed by 1, from 1 to 1.1, and his glucose has changed from 90 to 88. So my question to you is, which of the interventions listed below would be the most appropriate in this patient's case? What would serve her best? Would it be increasing the hydrochlorothiazide dose to 25 milligrams after breakfast, or would you continue the hydrochlorothiazide as is and add Lisinopril and ARB to it at a dose of 10 milligrams orally once a day? Or would you stop the hydrochlorothiazide and initiate a combination product, hydrochlorothiazide co-formulated with triamterene at half a tablet of the 50/75? Finally, would you continue the hydrochlorothiazide therapy as is without adding anything to the treatment? I'll give you 10 seconds to choose the correct answer. I would choose to be patient and continue the hydrochlorothiazide therapy as is without adding anything at the moment. The BP is still above goal, but it has improved slightly. Our goal for this particular lady is below 130/80. And due to the mechanism of action of hydrochlorthiazide, the mechanism by which it causes natriuresis, the maximum effect may not be seen for several weeks after initiation. It can even take as many as 12 weeks. Now, the addition of triamterene isn't necessary now, as the potassium level, while it did decrease as expected, is still within the normal range. And this patient's treatment, in my opinion, should be reassessed after 4 weeks before we rush into changing anything. Let's move to the next question, which reads, patients with CHF with reduced ejection fraction, HFrEF, are sometimes managed with digoxin. So my question to you is, which statement below most accurately describes the digoxin drug level monitoring and use in HFrEF? Is it the historic reference range was between 0.8 to 2 nanograms per ml, but now the evidence suggests the upper limit be around 0.8 nanograms per ml? Or is it historic reference range was between 4 and 12 micrograms per ml, but now the evidence suggests the upper limit around 6 micrograms per ml? Or is it the historic reference range was between 10 and 20 mics per ml, but now the upper range is suggested to be at 15? Or is it finally the historic range was between 50 and 100 mics and should now be upper limit 125 mics per ml? I'll give you 10 seconds to choose the correct answer. Settle for A. That is the most accurate. Now, the second choice is reflective of carbamazepine, which we are not dealing with now. The third option is reflective of phenytoin, theophylline, and vancomycin levels when doing TDM, which we are not dealing with now. And the fourth value is reflective of valproic acid, which we are not dealing with either. So I would go for alternative A. Let's move to the next question. Which antiplatelet agent would merit substitution in patients considered to be poor CYP2C9 metabolizers? Is it Clopidogrel, Prasugrel, Ticagrelor, or Ticlopidine? I'll give you 10 seconds to choose the correct answer. So Clopidogrel it is, in my opinion. Now, CYP2C9 poor metabolizer status is associated with diminished antiplatelet response to Clopidogrel in patients. Although a higher dose regimen in poor metabolizers increases antiplatelet response, an appropriate dosing regimen for this patient population has not been fully established. So that's just a by the way. Let's move to the next question, which reads, which of the following drugs is reversed using idarucizumab? Is it dabigatran, apixaban, edoxaban, or rivaroxaban? I'll give you 10 seconds to choose from that list of 4. So dabigatran is the correct answer. Now, idarucizumab, which is otherwise known as prescribing, is a humanized monoclonal antibody fragment which is indicated in patients treated with dabigatran when reversal of anticoagulant effects of dabigatran is needed for emergency surgery or urgent procedures, or when you experience life-threatening or uncontrolled bleeding after administering dabigatran. Now, dabigatran, which is also known as Pradaxa, is an oral direct thrombin inhibitor, just for your information. And apixaban, alternative B, edoxaban, and rivaroxaban are all oral factor 10A inhibitors. Their potential reversal agents are exenat alpha and siraparantag, a tongue twister indeed, just for your information. Let's move to the next question. So our next question reads, how do NSTEMI and unstable angina differ from one another? Is it true that NSTEMI is accompanied by more severe chest pain? Or is it true that NSTEMI is relieved by nitroglycerin? Or is it true that NSTEMI requires a higher LDL? Or is it true that NSTEMI can cause MI necrosis? Sorry, myocardial necrosis. I'll give you 10 seconds to choose the correct answer. Opt for answer D. NSTEMI may cause myocardial necrosis while unstable angina doesn't. Remember, in unstable angina, the occlusion is not as severe as in the case of NSTEMI. Patients with unstable angina generally will not have positive cardiac enzymes, as would be seen in patients with NSTEMI, with STEMI, or with a new left bundle branch block. Now, both NSTEMI and unstable angina can cause chest pain, so that makes option A wrong. And nitroglycerin may not relieve chest pain in NSTEMI or unstable angina. That makes alternative B wrong. And LDL doesn't impact CAD and ischemia. That makes alternative C wrong. However, a large amount of LDL cholesterol isn't specific for NSTEMI or unstable angina. So that's just a by the way, and that justifies why D is our correct answer. Let's move to the next question, which reads, a 54-year-old white patient with a past medical history significant of type 2 diabetes mellitus, hypertension, COPD, and who happens to be obese, claims to be adherent to his regimen and denies any complaints at the moment. He's tolerating his drugs well. And his vitals include the following. 12 weeks ago, he had a BP of 162/96. 4 weeks ago, it was 150/94. It had come down slightly. And in today's appointment, it's 144/94. His pulse hasn't changed much. It was 62, it fell to 62, and it's currently 60. And his weight has changed slightly. Initially it was 257, it increased to 263, and decreased slightly to 258. So when you look at his list of current meds, he's on metformin taken at a dose of 1 gram after breakfast and after dinner. In addition, he takes 10 milligrams of glipizide twice daily, 40 milligrams of Lisinopril once daily, and he inhales PRN salbutamol 1 to 2 puffs every 6 hours when necessary, and is on low dose aspirin at a dose of 81 milligrams once daily prophylactically. Now, 12 weeks ago his sodium was 138, it fell to 140, and today it's 139. His potassium was 5.1, it fell slightly to 4.9 and rose to above baseline to a level of 5.2. His BUN was at 15, it fell to 12 and has risen to 14. His creatinine was initially 0.9, it rose to 1.1 and it has stabilized at 1. His glucose was at 196. He's trying his best to manage it well. It fell to 174 and it's currently 163. And at baseline his HbA1c was 7.3. It has fallen slightly to 6.9. So based on the present data, which of the following statements is the most appropriate concerning this patient? Is it A, the BP goal is below 130/80 and we should start him on hydrochlorthiazide at a low dose of 12.5 milligrams orally once daily? Or is it that the BP goal is 150, below 150/90 and we should decrease the lisinopril dose to 20 milligrams orally once a day? Or is it C, the BP goal is below 130/80 and we should start metoprolol at a low dose of 25 milligrams twice daily? Or is it that the goal should be below 150/90 and we should continue the current therapy as is? I'll give you 10 seconds to choose the correct answer. So this patient's goal stands at below 130/80 and I would consider initiating low dose hydrochlorothiazide. So my best option would be A. Remember, he has hypertension in the setting of type 2 diabetes mellitus, therefore his goal is rightfully below 130/80. He has a high normal potassium and a low normal heart rate, in my opinion. Decreasing the lisinopril, in my opinion, would possibly assist in lowering the potassium level, but the BP goal in relation to lisinopril is wrong. Below 150/90 would be the wrong one for this particular patient. So answer B is not correct. Now, starting metoprolol would increase the patient's risk of bradycardia and may not result in a good BP reduction, given a primary mechanism of BP lowering in the beta blockers by decreasing the heart rate. We don't want it to fall very far down. Now, initiating hydrochlorothiazide would be the most beneficial, given the need for further blood pressure lowering and the added benefit of lowering the potassium levels. Remember, hydrochlorothiazide is slightly potassium wasting, so it will help us bring down the potassium levels and the pressure simultaneously. So that would be my best bet in this particular case. Let's move to the next question, which reads, which of the following side effects is associated with the use of high-dose niacin for the treatment of hyperlipidemia? Is it increased or an increase in uric acid, which would cause a gout attack? Or is it a decrease in blood glucose, which can lead to hypoglycemia? Or is it an increase in serum creatinine due to Fanconi syndrome? Or is it an increase in risk of gallstone formation, which can cause abdominal pain. I'll give you 10 seconds to choose the correct answer. So in my opinion, A is the correct answer. High dose niacin causes flushes, especially earlier on or when doses are titrated, and increase in uric acid levels also do occur, which can exacerbate gout, and it also does cause hyperglycemia, not hypo, so that makes answer B wrong. Apart from that, it reduces uric acid secretion, it increases uric acid reabsorption in the kidneys by interfering with what we call the URAT1, and may also increase uric acid production. Now, increase in serum creatinine is due to Fanconi syndrome is not associated with niacin. It is associated with drugs such as TDF, tenofovir, disoproxil fumarate, ifosfamide, and the aminoglycosides. So C would be the wrong choice. And we also know that fibrates and gemfibrozil are known to increase the concentrations of cholesterol in bile, thereby leading to greater risks of crystal or gallstone formation. So those are the drugs that could cause an increase in gallstone formation, not niacin. High dose niacin is sometimes used to treat dyslipidemia, especially with hypertriglyceridemia, when the TG is above 500, when other agents are not available or intolerable. So it does not cause an increase or a risk in gallstone formation. So that makes answer A the best bet. So my dear viewers and listeners, that brings us to the end of part 21 of our Pharmacotherapy MCQs series. I'm very thankful you made time to sit, to view, and to listen. Now, if this video helped you in any way, I would like to remind you to give it a thumbs up, to like it. And if you haven't done so, I would like to prevail upon you to subscribe to my YouTube channel. I would like to promise you from the bottom of my heart that the best is yet to come. Thank you for viewing and for listening, and I hope to interact with you in part 22 of our Pharmacotherapy MCQs series. Thank you for being there for me.